Welcome to Health Affairs from A to Z. This program is brought to you by CAN TV and the University of Illinois at Chicago College of Nursing. I'm Nancy Valentine, PhD and registered nurse, and I am an associate dean at the College of Nursing and a professor as well. And I'd like to introduce my colleague today, Dr. Holly Devon. And before I tell you a little bit about Dr. Devon, I'm going to tell you about our topic today. And it's really one that implies everyone that's listening to this show. So you are welcome to call in and ask any questions about this, but today our topic is women and heart disease. And we're going to focus on three particular areas of interest, three things that you really need to know in order to protect yourself and to be more knowledgeable about this disorder. So let me introduce Dr. Devon. Holly Devon is also a doctorally prepared nurse, and she is a scientist at the U.I.C. College of Nursing. And her area, of course, is women and heart disease. She is doing very cutting-edge research because until people like Dr. Devon started looking at women and their symptoms, most of our knowledge was based on men and heart disease. Surprise. Most everything starts out with most people studying men. But once we get into studying women, whether it's for heart disease or alcohol and drug abuse, we see that there are differences, and it's really those differences that we're going to be talking about today. So her research focuses in on these kinds of symptoms that really are different for women than for men, and she's going to tell you about that. And she has developed this very cool tool that is used in many countries throughout the world in emergency rooms, and it's a symptom checklist, and she'll tell you a little bit about that as she's talking about this topic in general. And this symptom checklist really helps to nail down whether the person presenting in the emergency room is indeed having a heart attack or not. So again, you are more than willing and invited to call in and ask any questions about this. If you've had this experience, or if you know someone, or if you'd like to have some more information, please feel free to do so. So with that introduction, thanks, Holly, for being with us. And maybe you could start out and give us some idea as to why we should even be interested in this topic.
Well, thanks, Nancy. Thanks for inviting me. It's just great to be here today. And this is my favorite topic, to talk about heart disease in women. And the reason I like to talk about it so much is because many women do not realize that heart disease still remains the #1 killer of women. Unfortunately, cancer deaths are climbing in many states. About 22 states now report that cancer is the leading cause of death, but overall in the United States for women, heart disease is the #1 killer. And I think that, well, we know from many studies that women's awareness of their risk of heart disease remains quite low.
Right.
And in fact, Dr. Lori Mosca from New York has done a series of studies on women's awareness, and she has actually found that for women of color, both Latinas and African American women, their awareness of their risk of heart disease has gone down from 2009 to 2013. And for Caucasian women, it's only about 50%. So we have a lot of work to do in letting women know about their actual risk and how they can be on guard and reduce their risk.
Right. Let me just show you this really cool picture that Holly has in terms of this women and heart disease. And if you can read this on your screen, as she said, it is the #1 killer of women, and it's more deadly than all forms of cancer combined. Now, I think that is in itself like a newsflash for most people, because most of us think of breast cancer or cancer of different types. And so heart disease causes 1 in 3 deaths of women each year. So if you know 3 women that have died this year, last year, the year before, at least one of them probably has died of heart disease. And I think this is an estimated 43 million women in the U.S. are affected by heart disease. So I think this is a very good visual snapshot of what we're talking about. And maybe you could tell us from your experience, why do you think we sort of we don't realize that heart disease is so prevalent, that we tend to focus more on cancer? You have any thoughts on that?
Yes, I do. I think that women are fearful about a cancer diagnosis, and I think that there's reasons. Thinking about breast cancer in particular, I think that women have rallied around
Right.
getting the word out. Think about breast cancer awareness, Susan G. Komen Foundation, American Cancer Society, the Pink Ribbon. They've been very successful in getting the message out. And yet, approximately 215,000 American women will die this year of heart disease, while only about 40,000 will die of breast cancer. And I don't mean at all to
Right.
suggest we shouldn't be vigilant about having mammograms and doing breast self-exam, but we just need to understand that the preponderance of risk is with cardiovascular disease and particularly heart disease. So that in the same way that we have mammograms done, we should be screened for high blood pressure, we should be screened regularly for blood sugar, for lipids or fat levels in the blood, routinely from adulthood on.
Okay. So I think that's a really good point. Somehow it seems that for, let's use breast cancer as an example, there's really sort of a face of women. You have this sort of visual idea of women that have died of breast cancer, or even if you haven't had a personal experience, you sort of have that Susan Komen. It has such a personal aspect, whereas I think that the Go Red for Women is a campaign that's put on by the American Heart Association. And it's a very, very cool thing that is done every February, and I think they get a lot of interest, but it doesn't have that sort of personal face attached to it, I think, as some of the cancer programs have. So that means we have to do a better job of communicating with women, which is what we're doing today with this program, to try to build that awareness.
We do. The Go Red for Women is a very good initiative. It's a lot newer than the breast cancer initiatives, but I think this has helped us make some progress. Many women, for example, Rosie O'Donnell, had a heart attack when she was only about 50 years old. So we've gotten celebrities on board to help us get the message out. But this is a great way for us also to reach people.
Right.
So we love to talk about how we can reduce risk and how we can be in tune to our bodies and be aware of symptoms that should cause concern.
Okay, well that's good. Well, that's what we're going to learn about today. We're talking about those early signs and warnings, and as Holly has already said, the things that we should be tested for on a regular basis that are sort of markers that really help us to be in tune with our own bodies and be more self-aware of what we can do in a timely way. So tell us more about what those things entail.
So we've done a series of studies since about 2000, and we have focused on sex differences and symptoms because, as you mentioned in the beginning of the program, prior to 2000, most research on heart disease included only men or a very small amount of women. So we said we're going to enroll equal numbers of women in our study, and the reason that I was particularly interested in symptoms is because symptoms are what causes all of us to seek treatment. And in the case of heart disease, we now have very good therapies to intervene when people are having a heart attack, both men and women, but these therapies are time dependent. In order to help salvage heart muscle, which is what happens when you have a heart attack, it damages your heart muscle and can lead to heart failure. We can intervene, but it has to be within about 3 hours of time. So if we know what symptoms to look for, we can get help quickly and in many cases have procedures like angioplasty or drugs that can break up blood clots and help salvage myocardium. But we were very interested in knowing if there was differences between men and women, so we could speak like this to women and tell them differences. So interestingly, over the years, we have consistently found differences in symptoms, but overall, women and men are more similar than different. But what I would like a take-home message to be for women today is that shoulder pain and arm pain is a very sensitive and specific symptom for heart attack in women. It's not that men don't sometimes experience arm pain and shoulder pain, but in our studies we've found these to be specific for women. So I would want to say to both women and men watching the program that chest pain, chest pressure, chest discomfort is a hallmark symptom of a heart attack. And when they experience that, they should seek care
Immediately.
Immediately. In fact, American Heart Association says that you should call 911 within 5 minutes of the onset of symptoms. And I'm sorry to say that in our most recent study, only 44% of our participants called 911. Now, we included men and women who were both ruled in for heart attack and those that had other problems that brought them to the emergency department that day. But nevertheless, the majority of people do not call 911.
Right.
And so we're trying to reach people and say that it's much better to be safe than sorry. People tell us in our studies that they're worried that it'll be a false alarm, but the people in the emergency department are waiting for you. The paramedics in the fire department, who are superbly trained, are waiting for you to call, and they would join me in saying it is much better to call than to try to problem solve and wait around, because we know those types of behaviors are associated with longer delay, and if you delay, then you're less likely to have effective treatments.
Right. So let's see if we can walk through that, because we know it's sort of human nature. Obviously, less than 50% really do the right thing in that very short period of time. Most people try to rationalize, well, maybe it'll go away, maybe I have heartburn, let's sort of see how it goes. So how can people make that differentiation? Like, for instance, when you said, unless it's a crushing chest pain, but say you have some chest pain, you have some arm pain, how would people know that, hey, maybe I've got arthritis, maybe I exercise too much? Can you tell us about how it feels different?
Yeah, that's a great question. And that in itself is a misunderstanding, because the majority of patients having a heart attack, both men and women, do not have crushing chest pain.
Right.
They're much more likely to call it chest pressure, or to tell you it feels like there's an elephant sitting on their chest, or it's very difficult to breathe, shortness of breath is behind chest symptoms is the second most expressed symptom,
Right.
For men and women. So, and it's not only not crushing, but in many cases it's not particularly severe. So this leads to confusion, and it's very understandable. So in the emergency department, we say the majority of patients come in undifferentiated. That simply means we don't know what's wrong with them until we do a workup. We don't know what's wrong with them until we do diagnostic testing. And so they don't know either. And interestingly, we did a study a few years ago, and we looked at a long list of factors that were associated with delay in seeking treatment. And interestingly, the most serious form of a heart attack, which in our lingo is ST elevation, and continuous symptoms were the only two factors that were associated with increased time to get to the emergency department. So one problem with the pain of a heart attack is it often comes and goes. It's intermittent. And what people ordinarily do when they feel sick is rest. In many cases, they lay down and they start to feel better. And so the symptoms go away temporarily, and then they're less likely to think it's an emergency. And I like to caution patients that the symptom may go away, but the condition does not.
Right.
So don't fool yourself into thinking it's not serious. Of course, if you have risk factors, we risk stratify patients. So if you have common risk factors such as smoking, high blood pressure, high lipid levels, high cholesterol, and for women, certain, especially younger women who may be premenopausal, if they have a history of pregnancy-induced high blood pressure or what we call gestational diabetes, those are risk factors that we all need to be aware about our own health history. So if you have risk factors, you may be more likely, of course, to have a heart attack. But the key thing is we don't know until we get tested. And so it's really important to seek care. So that's the message we're trying to get out.
Right. So let's sort of try to digest that. So what we've learned from this thus far is that the people that are having crushing chest pain are rare, very, very infrequent. And if by that time, it's probably too late in many cases because you might be like blacking out shortly thereafter. It's more likely that you're going to have this sort of like strange feeling of pressure, maybe some shortness of breath, some pain in your arm, and one arm or the other?
More typically left shoulder and left arm than right, but people
Okay.
have reported both arms.
Okay, so it could be more dominant in your left, but it could be also in both arms. So the question is knowing your body. So you are the best assessor of anyone else. So rather than say, oh, this will go away, as we heard, the symptoms may abate slightly, but the underlying condition, your body is giving you a notice signal that there is something wrong that is not going to go away. It's already progressing, and you will need medical intervention. And that's what we're trying to elicit your interest that if you ever had that or you knew someone that was having that and you were with them, it's better to be cautionary and really have it checked out rather than to try and rationalize that it's just something that's going to pass and go away, because it really won't. I mean, this is not something that repairs itself on its own, no matter how much you would rest and hope that it does go away. So you used a big word called risk stratification, which the average person is not going to know what that means. So I think what we want to hear more about is, in this idea of knowing your own body and really respecting it, what are the kinds of problems that if people have, they should say, I may not ever have a heart attack, but my chances are much greater. So walk us through those again.
Okay. So I'd really like to also take the opportunity to say we're primarily talking about women, and I have alluded to men too. But an interesting thing about women is, and when we use the term women's health, we often think about reproductive health. And women are more likely to get obstetric or gynecologic care. And once they're a little bit older, maybe still premenopausal, they don't necessarily get follow-up care. So they're not monitoring these important things like their blood sugar levels, their cholesterol levels, their blood pressure. And these are components of what we call risk. So if you have things like high blood pressure, then you're at a higher risk for developing heart disease. And if you don't have these risk factors, it doesn't mean you aren't at risk, because you always have to take into consideration family history. So these are the things that we would like you to consider, whether or not you have a family history of heart disease, particularly if you have family members, immediate family more so than extended family, but immediate family who developed heart disease. For men under age 55, for women under age 65 would be considered premature heart disease. So if you have family history, you should monitor yourself closely. Of course, if you have traditional risk factors, a couple things I haven't yet mentioned that are really a problem in the United States right now is type 2 diabetes and overweight. Those are very predominant risk factors. They're very common now. And so I would think about all the things that we've mentioned as the risk profile. So if you have symptoms, if you come to the emergency department, they will look at those risk factors. Even if you called a physician or went to the clinic, they'd evaluate the same things. But I have to tell you, in our studies, we have enrolled participants with heart attacks from age 24 to 98. And we have actually found many differences are associated with aging. So I really want to tell women in particular, but men as well, do not say, well, I'm not feeling well, I have a little chest pressure, I'm a little short of breath because I'm deconditioned or I'm out of shape or I'm getting older. We assume that as we get older, that we might not feel so good, and that is erroneous. As you noted, chest pain can be caused by a number of other conditions. Most notably, musculoskeletal issues or arthritis can cause chest pressure or pain elsewhere in the body. Anxiety can cause shortness of breath and chest pressure, or lung problems as well. So going back to what we had talked about early on, the whole idea of can we know with certainty what's going on? No, we can't. But we want to err on the side of considering new symptoms to be serious rather than say, for as you said, I have heartburn or GERD. I've heard that so many times I can't tell you. And women are particularly good at saying this is not important or I have a lot of responsibility. And we know that that is the case. Women are generally the caregivers of the family.
Right.
And they often are caring for elderly patients, or parents rather. In many cases, grandmothers are taking care of grandchildren. And even those, we've had healthcare professionals in our studies say, well, I thought it was something else, even when they have this detailed knowledge
Right.
of pathophysiology. So I would highly encourage our listeners to develop awareness of their body and not to say this shouldn't happen. One thing you also mentioned that I want to highlight is approximately half of patients who develop heart disease, the first symptom will be sudden cardiac death. That's a cardiac arrest. And the survival rates are not good from cardiac arrest. There are defibrillators available in many public places now, like schools, airports. So I just want people to be aware that they shouldn't panic, but they should take the risk of heart disease seriously.
Right.
And seek treatment sooner rather
Right.
than later.
Right. Well, I think that what the action items are for you in this is that, again, not only do you have to know your body, but you have to also know your family heritage, if possible. So it's not a bad idea to sort of walk through everybody in your family and make a little chart, family tree, as you're maybe doing that anyway, and figure out who died of what. To the best of your knowledge, and try to dig a little deeper if people don't seem to know that right at the first blush of that question. Because if you find that there are people that had heart disease early on, and there are certain ethnic groups that are more prone to this, it's really important to track on that, because it's almost like telling your family's story. Your chances of risk then are greater if you come from a family that has heart disease, just as if you came from a family that dies predominantly of cancer. There are some genetic markers in this whole conversation that are going to put you at risk. And when I say at risk, that doesn't mean like it's a depressing experience and there's nothing you can do about it. It means that you need to be more alert and more watchful. And I think the other action item in this discussion is really to have your annual physical, to know what your numbers are, to know what your blood pressure is, to really have someone assess you, because then there are all kinds of things that can be done as a prevention. And I think the other myth is that people walk around thinking, well, medical science is now so sophisticated. If I have a heart attack, I'll just go get a stent, or I'll get this, or I'll get that. Not everybody even gets that far. A lot of this is all or nothing. Some people never survive that first experience because it's too late, or they waited too long.
And that is what I would like to reinforce what you just said, Nancy, is that if you have symptoms and you think it's a possibility that you're having a heart attack, please don't drive yourself to the emergency department or take public transportation. Please call 911, and before you do, chew 2 aspirins, which can help minimize blood clotting.
Yes. So I think that what we hope we did today, Dr. Devon and myself, is that we have had this discussion with you, and hopefully you will share it with other people. And if we have saved one person by really just keep hammering away at this idea that it's better to be safe than sorry, it's better to really seek help before you absolutely need it, then I think we will have done our job for the public of the citizens of Chicago today. So there's a lot more to talk about this, and maybe we'll have Dr. Devon come back for a second discussion of some of the things that we can do together to really prevent heart disease in this country. Thank you very much for watching, and have a wonderful day. And remember, with health, all things are possible. Have a wonderful evening.